Good afternoon, everybody. Good evening. It says here good evening, but I think we should say good afternoon because we don't want to wish the evenings on too quickly. But welcome to the Healthwatch Norfolk Dental Summit. This is a chance for us all to take an in-depth look at the issues around dentistry, a subject which we at Healthwatch are hearing about a great deal at the moment. As you may know, we hold an event called Healthwatch Live every year to recap our work. But this year, we felt we needed to focus on dentistry because it's such a priority for so many people who contact us. This evening, we'll start with a quick recap of our work over the past 12 months. And if you want to read more, then you can also pick up copies of our annual report, which are here, and come and talk to any of us afterwards. The reports are just over there. I'll then be handing over to our guest presenter this evening, Anna Perot, who will take the helm of the main part of the evening, introducing our work around dentistry and finding out more about the challenges. But before I do that, I should probably just go through a little bit of housekeeping, which is, first of all, the vital thing about coffees and drinks, and please help yourselves from here. And there are biscuits on the right if you feel that way inclined. The loos are in the foyer where you came in, and should there be a fire alarm and we're asked to evacuate, then please make your way out through the foyer. If that exit is blocked or there's smoke and flame coming from it, then up these stairs and out of that door. And I should also like to say a big thank you to AstraZeneca for their kind donation that has helped to make this evening possible. So, let me start with a brief recap of our work over the last 12 months. The overarching theme of the Healthwatch network over the past year has been the value of listening. That's been very much at the core of what we've been doing as we head out around the county to meet people and hear their health and social care experiences and get involved in some major projects. These have included visiting a number of residential care settings and hear their health and social care experiences, and to people with learning disabilities or autism. And our whole team spending a week in each of Norfolk's acute hospitals, finding out what patients, their carers, and staff thought about care providing vital feedback. Let's take a look back at the last 12 months, condensed into about 6 minutes in this review of the year.
The value of listening. It's at the core of what we do. Hearing from people about their health and social care experiences helps inform our work. Whether it's engaging with communities across Norfolk in care or community sites, helping people who call in to us, or working with different communities to understand their concerns in more detail, we need to listen to what people say and pass those views on to those who shape our services. Our role is to analyse and spot trends, act on feedback to drive change and improve services, and help make a difference to people's lives. We do this by working in partnership with care providers, the government, and the voluntary sector. So just how many people have we spoken to over the past year? 2,540 shared their experiences of health and social care with us. 282 came to us for advice, and our team carried out 101 engagement visits to GP surgeries, pharmacies, libraries, care homes, community centres and community events. In addition, the entire team spent a week in each of Norfolk's 3 acute hospitals for the 3 Hospitals 3 Weeks project. In total, 5,417 experiences formed part of our targeted engagement and projects for the past year. As well as the general engagement we do, we also carried out some targeted work too. Because of concerns around pharmacy care, we visited pharmacies and dispensaries around the county, hearing from over 1,000 users and 46 professionals. While people were generally happy and thought they were treated well by staff, we did recommend better communication between GP practices and pharmacies. And pharmacies were also encouraged to talk to patients in multiple ways, including social media and text messages. One of our major engagement projects for the year was 3 Hospitals 3 Weeks. It saw our entire team spend a week each at the Queen Elizabeth Hospital in King's Lynn, the James Paget University Hospital in Galston, and the Norfolk and Norwich University Hospital in Norwich. We visited as many wards, clinics and departments as we could, speaking to patients, carers, visitors and staff. Most were happy with the care they received, but there were concerns about waiting times, cross-departmental communication and parking. Talking of reports, we also published many more linked to our My Views Matter project, which saw us visit residential care settings for those with learning disabilities or autism. As well as publishing individual reports based on the feedback we received at each site, we also pulled together the key themes we discovered for a full report. We did hear a lot of positive feedback, and most people felt they had an avenue for ensuring their voice was heard, something that didn't happen at Corston Park, the site which triggered our work in the first place. There were some areas for improvement though, including the building of stronger relationships between staff and residents. Ensuring managers were well informed and engaged in the life of a home. Trying to make living spaces as personalised as possible for residents. And ensuring relationships are maintained for those residents with both their parents and immediate family and older friends. Other project work we got involved with through the year included getting the views of communities around proposals for a major trauma centre to treat some of the most serious injuries here in Norfolk. Finding out how easy people found it to engage with the Care Quality Commission if they were homeless or of no fixed abode. Discovering how easy people found it to access long COVID support in Norfolk, and the experiences of those transitioning from being looked after as a child to an adult within Norfolk Community Health and Care. The team also gathered feedback from people on the care they received at the Benjamin Court facility in Cromer, and carried out a training programme for the governors at the Queen Elizabeth Hospital in King's Lynn. Our phone lines remained busy. Around a third of the inquiries we received were linked to difficulties accessing NHS non-emergency dental care. Because of this, we're gathering people's dental experiences over the spring and summer before holding a dental summit in the autumn to look in more detail at those issues. We also helped people with a wide range of other questions, which include helping to access bereavement support, helping a 16-year-old access urgent help as he was homeless in Norwich, advice on the rollout of prescription drugs or other treatment, difficulty in getting a prescription, helping a mum get support for her 8-year-old's anxiety, and even working with a surgery to improve its signage following patient feedback. Sharing public information and advice is also important, as well as our social media channels and our fortnightly newsletter, which reaches over 5,000 people. We also created content to help people understand what the new PSUF system is around looking into patient safety incidents and how people can help with this process. Continue to highlight the availability of free NHS health checks for the over 40s. Shared information about the Carer's Identity Passport, which helps unpaid carers identify themselves in health and care settings. And also explained how people can now access their GP records online if they wish. The listening is going to continue for the next 12 months as we continue to engage with those with serious mental illness, their families and carers about their experiences. Our team will also continue their focus on social care, trying to talk to even more people in care homes to discover what they think about how they're looked after. Our project work will continue around accessing care digitally in conjunction with the ICB. And we're also going to be working with the Queen Elizabeth Hospital in King's Lynn to help with the recruitment and running of their new youth council for 18 to 25-year-olds for its first 12 months. Whatever you want to raise with us, we're here to listen and gather the feedback of people across Norfolk about their health and care experiences, help them find ways of obtaining further support if they need it, and make sure health and care leaders hear what we're being told so they can shape future services. So please, keep sharing your stories and experiences to help us prioritise our work and help health and care leaders prepare for the future to provide the best services they can for you.
It's been a very busy year. As I mentioned, there are copies of our annual report here tonight with more information. Please come and talk to any of the Healthwatch Norfolk team if you'd like more information about what we do. Let's now move on to the main business of the evening and our focus on dentistry. It's my great pleasure to introduce our guest presenter for this evening, Anna Perot. For anyone who listens to BBC Local Radio, Anna was a very familiar voice, presenting just about every programme on the station and bringing her mix of gravitas and entertainment to the airwaves. When the BBC went through some changes, Anna took the plunge into the freelance world, setting up Soundyard, which specialises in creating podcasts and audio content. We're delighted she's here tonight to host this summit. Ladies and gentlemen, Anna Perot.
I want to assure you I wasn't on the radio 24/7. That would be awful. It'd feel like it sometimes, so. It's a real joy to be here this evening. Thank you very much indeed. As it's mentioned, we are talking dentistry, but I don't want you to feel that the biscuits are therefore out of bounds for everybody, because it's all about balance. And there's the enormous toothbrush there that I think we should have photos with later. Brilliant, love it. So dentistry has been a huge issue for Healthwatch Norfolk and for people living here. So throughout this evening, we're going to present a few case studies and patient stories of those who have contacted us specifically with their experiences of accessing dental care. The feedback that we've received from Healthwatch Norfolk has been instrumental in putting together the report. It's been so important to get a variety of people's feelings and experiences for that. So the whole theme of today came after the team sort of decided to ask the public for their views, their experiences and their feedback around the NHS dental care. Some of the Healthwatch Norfolk team join us now to talk us sort of through the key findings of the report, and they're particularly interesting. So take it away, Reece and John.
I'm going to use the microphone because I'm losing my voice slightly. So Healthwatch Norfolk decided to take a look at the situation around NHS dental care in the county. Why did we decide to do this? Well, a number of reasons for that, really. It's accounted, as the video showed earlier, for a substantial amount of our inquiries we received by phone, online and email over the past 3 years. In fact, an average of 40% of our inquiries in the last year were down to people being unable to get NHS non-emergency care. We did some detailed research for the government's Health and Social Care Committee 2 years ago, alongside other Healthwatch in England. We then repeated this exercise 12 months later and found things had got worse. And knowing how difficult the situation was, we decided to focus one of our annual public events this tonight on the issues around dentistry. So how did we gather people's views? Well, our 2 previous pieces of work were based solely around ring rounds of dental practices in the county, and also analysis of our digital feedback centre where people can leave their views and experiences that they've had. This time we decided to be even more proactive and go out to the public and ask for their data and their experiences. This would give us the opportunity to understand more of the detail around the issues about getting care and drill down into those in more detail.
Yes, so let's take a look at the figures and sort of who we heard from. We received 221 responses to the survey, of whom over half, or 63% even, were female. Interestingly, over half of respondents had either a disability, long-term health condition, or both. And the biggest proportion of participants came from the South Norfolk area. From our analysis of people who shared their experiences, around 3/4 said that they'd been unable to receive a non-emergency NHS dental appointment. The most common reason was that no NHS dentists were accepting patients, followed by practices opting to only take private patients. Of those who did get a non-emergency NHS appointment, most received correspondence confirming that appointment more than 2 months after their first inquiry. We also asked people about emergency NHS dentist appointments. 43% of people said they had needed one, but just half of those respondents then said they were unable to get one, having initially inquired. Of those who did receive emergency appointments, half of those respondents were given confirmation of an appointment at least 5 days after their initial inquiry, and over half of the people who did receive an appointment found the experience to be bad. There was also concern expressed by many that NHS dentists are switching to practicing privately, and some people felt they were also telling us they were resorting to self-dentistry as they felt there was no alternative. Several people also reported issues getting through to the 111 service, although we do understand efforts have recently been made in recent weeks to deal with this, and we can touch on that sort of in more detail later.
We're also keen to understand the challenges around access to NHS dentistry for children, and again, going through some of the key statistics, we found nearly half of those who needed an NHS dental appointment for their child couldn't get one. We did hear, though, that it was faster to get emergency care for children when an appointment was offered. In fact, many of those appointments were being given on the same day, and most within 5 days of an inquiry. And also, in a change to the adult survey response, almost half, 47%, said they found their emergency appointment experience for their child to be good. We know that out-of-hours dental care is a future priority for the NHS locally, and we used the opportunity to find out how far people will be prepared to travel to access this. And the most popular response from just under half of those who participated was 30 to 60 minutes.
Some of the other key themes which emerged were the financial concerns of the cost of dentistry, of private dentistry. The number of people who are also resorting to using sort of self-help kits, and sort of, people using, or reports of people using sort of PVA glue and such to sort of fill fillings, which was amazing. Transport-wise, Norfolk being fairly rural with an ageing population, a lot of people expressed concerns about having to travel long distances on public transport potentially to get to a dentist. So what does this mean in general? In line with what we're hearing in a number of surveys locally and nationally, there are issues around NHS dental access for both emergency and non-emergency care. This means that people are either waiting a long time, struggling to access it when it is available, or in a few cases trying to treat themselves. Access and emergency treatment has also proved to be an issue, and it's particularly concerning that people can be left in extreme pain for extended periods of time, depending on the nature of their health issue. The issues around children do get some interesting themes around access, and although we did not get the same volume of feedback as we did for adult care, there were difficulties still around access, and although once an appointment was booked, there was a short time period before the child was seen, and people were sort of generally happy with the care that their child received. Like we said earlier, there's copies of reports on the side there, and you can't really see it properly there, but we do have a QR code, and it's on the website as well, if anyone wants to take a look.
So what are our recommendations? We've made 5 in total. They are improving access to NHS dentistry, so improved access to non-emergency appointments and checkups could reduce the pressure on more urgent care, hopefully treating things before they get more serious. Increase the availability of emergency and out-of-hours appointments. We felt waiting more than 5 days for an appointment while in pain is just too long. An out-of-hours service would be a welcome provision, providing the travel time for most people is no longer than 60 minutes, and a big challenge in Norfolk, we know it's accessible via public transport. Extra consideration for the vulnerable with better signposting information and a more widely available home visit service. And as Rhys touched on just there, the importance of NHS dental care to children and young people to help head off problems in later life. But I say, if you've got any questions about that, do come and talk to us later on, and I'll hand you back to Anna.
Thank you. Again, a huge thank you to anyone who did participate in the survey. Let's hear from another case study now.
Well, back when I was a child is when I started having problems, but I had an NHS dentist, so that was fine. And then my NHS dentist closed down last year, but failed to let any of the NHS patients know that they were closing down. And then I had a problem with my wisdom tooth, which I put off for a couple of months. Got worse and worse, so I had to ring round and see if anyone was taking on NHS patients in my local area, which is quite a few dental practices in Diss. I think there's 3 or 4 now. None of them were taken on NHS patients. So I had to go private in the end, and it cost me £165 to see a dentist in a week's time. So I had for the £165, I had 2 sets of x-rays, and for him to tell me there's not really anything wrong. So that was fine, and he took some pictures. But then obviously from the x-rays, he noted that I needed to have some fillings done, which in that appointment, he quoted up how much it would cost, which was including the 165 I'd already spent, and added to the £900 for 3 fillings was over £1,000. I mean, how families, single parents afford it, I don't know. I mean, you'd have to put it on a credit card, or because you can't live in pain, or you'd have your teeth pulled, wouldn't you? Because that's cheaper than having a filling or a root canal. To have your tooth pulled is cheaper. Yeah, so I work in A&E, so probably get about 10 to 15 patients a day with dental abscesses who can't access NHS dentist. So they come to A&E. We have to tell them on the front door we don't have dentists, and the most we're going to do is prescribe you antibiotics. And you will have to go and find a dentist after the course of antibiotics. But then you'll notice that in a couple of weeks they'll come back with the same issue again. There's not going to be a quick fix, I don't think. And I think we're going to see in the years to come children with terrible teeth that are going to need extensive surgery, and it's going to actually inevitably cost the NHS a lot more money because of not being able to access a dentist. It's not really fair.
Does that story resonate with people's family experiences or your own experiences with that? That's really, nodding heads. It's, she's not alone with that at all. So we're going to have a look at the challenges around providing dental care in Norfolk, because as it's been mentioned before, it's a rural county. The services are difficult to access. Before we talk to our first guest, on the screen is our first question, as you can see it on there. Now, one thing that will crop up a lot today is around preventing issues affecting your oral health. Now, while we chat to sort of our first panellist, do feel free to share your thoughts about what more we can all do within our sort of health and care system around help and support that would be useful to you. So I think everyone's been told to sort of use the QR code, you can ask questions and type questions on there. We also have a roving microphone, so we can come and ask anyone who's not feeling tech savvy and can't be bothered to do that. It's also absolutely fine. So in the meantime, I'd really like to welcome Tracy Bleakley, the Chief Executive of Norfolk and Waveney ICB, which oversees dental care, on our behalf to sort of talk through some of the issues in more detail. So you're very welcome. So one of the main issues that came up there, Tracy, was about access, not only to do with accessing an appointment, but the whole locality issue as well. How do you think that can be addressed?
So I think, well, the first thing to say is thank you to everyone who's come along today, and a big thank you to Healthwatch for doing this study as well, because we need to hear what it's like on the ground. And as you say, we've got a very diverse rural community, so it's really important for us to know where the real pockets are of inequality and in access and some of the issues so that we can address them. And I also think it's important to say that this is an issue that's been around for a little while, certainly has been getting a lot worse since the start of the pandemic. And so it might sound like a strange thing to say, but in Norfolk and Waveney Integrated Care Board, we're really pleased that we took over responsibility for dentistry last April, because it's given us the opportunity to do something about it. So prior to that, dentistry was all managed across the east of England. It was managed out of Cambridgeshire. we really didn't hear from that team very often. I don't think our dentists heard from that team very often. And so some of those local issues and just the little things that you can do that can make a really big difference just weren't being done. And if I give you an example, and I'll make the team blush, but there was a dental practice who in August last year was talking about terminating their NHS dentistry contract. They really didn't feel as though they could make it work. And not only did they keep it because we worked with them, but in August this year, they've applied to become a foundation dental training hub. So that's a really good turnaround. And it just shows what can be accomplished if you're working with dentistry practices on the ground. And another, I think, really interesting stat, we're desperate to make a difference and make a difference quickly. Just like the lady said in the case study, it's going to take time because it's not just about throwing money at the problem. We need dentists. But in the whole of the last financial year, from April to April, NHS dentists took on an additional 3,780 patients across the whole year. This year, from April, just in the first 5 months, so April to August, they took on 20,000 new patients. So it is making a difference. It's going to take time, but it is making a difference. I think the important thing as well is that we have been working on strategies. So straight away, we decided, what do we need to focus on in the short term? And that was urgent access to dentistry. And we have had some issues, and thank you again to Healthwatch that have been helping us work through that with some of the processes with 111, access, locality, etc. But we have 23 dentists now who are providing this urgent service. They're providing 1,900 appointments a month, and we are really keen to extend that and grow that as well and work with dentists to provide more of that and also to provide more of the out-of-hours service. And then in February this year, we started thinking, okay, our longer term plans, what is it the public want to see? What resonates with the public? So we did some stakeholder analysis, and it really does chime with what Healthwatch have found here. So we had consistency. It was 92.3% of the public agreed on the core principles, which you've talked about here. So it's about improving access. It's about improving that knowledge as well, oral hygiene and care, focusing on children and young people, urgent treatment services as well, and out-of-hours service, and also supporting our workforce, really, so that we can make sure that we have sustainability and long-term access. And while that does take time, we've been able to offer golden handshakes. So we've stolen dentists from elsewhere. Don't tell anyone. We've managed to attract 23 dentists from other places over the past year, which is the most we're allowed to do. But also 5 other dentistry professionals as well. And we've sponsored 5 dentists to come over from other countries. So small start, but we're hoping that by December this year, there'll be another 160 places available for NHS dentistry, and we're keeping working on that. So small steps, but definite progress.
Yes, absolutely. Yeah. One of the areas of improvement was going to be out of hours care. Even if money is there, how is that going to be started? Is it through those people coming in? And you said there's a cap of 23 that you can bring in. Why is there a cap there?
Basically we can't steal all the dentists around the country. So we have to play fair with other areas. So we've attracted new ones in, and we'll talk a little bit about the dentistry school later and plans. We want to grow our own. And important to say that the team are going out speaking to foundation dentists as well. So newly qualified dentists, telling them how lovely it is to live in Norfolk and Waveney, because it is. So trying to attract as many people in as possible before they even start work. But I think the important thing, if we want to ramp up a service like this quickly, inevitably we are talking to our current providers. We are talking to dental practices that are already here and saying, can we extend your services? Can we extend the hours? Can we make you a training provider as well, so you can help train new people coming in? And can you provide more out-of-hours services and urgent treatment? And that's basically where we've got the majority of this coming through.
Yeah, that's great. You've mentioned about the emergency appointments via 111.
Yeah.
And that previously being a problem, probably is still a bit of a problem, but there has been work that's been going ahead. Can you tell us about what's been going on with that a bit more?
Yeah, so we've been working in more detail, not just with the 111 service, but also how they interact with each individual practice. Because, with the best will in the world, they've got to have the right phone number. We've got to make sure that there's somebody manning the calls when they're coming through, understanding the different hours the different practices are working. And also just a little bit about travelling time, as you say, and how people can get to the different practices. So certainly people have been writing to me personally. I read and answer every complaint that comes through to the ICB, and we've been really addressing that and working with our friends at Healthwatch as well to make sure that we get as much information as we can from the public about why it's not working, and then pass that back and address that.
Yeah, everyone leaves it too late. I imagine. We've got to leave it to this point. Yes, yeah, we've all.
Well, yeah. We all put off dentistry, don't we? I do. Yeah. I shouldn't say that when there's a dentist in the room, but yeah.
There we go. It's very human. Well done. We will be talking more about prevention a bit later on, and specifically about children and young people. What can we do around the potential sort of time bomb of oral health issues for future generations, do you think?
I think a lot of it is around prevention. It's also about good habits forming. So we are working with schools around oral hygiene and good habits, doing really good work with our friends and partners at Norfolk County Council and Suffolk County Council as well on prevention and getting out to schools, but getting out to wider community. We have the Healthy Smiles project as well, which is working out in community with children and families. And I think it's slightly wider as well. The work that we're doing around healthy eating, ultra-processed food, for example, it does make a big difference to how we eat. It makes a difference to our teeth over time. So much research has been coming through about that. And, this is Norfolk. We grow so much of our own food. We have so much healthy food available. So just looking at some of those wider areas as well. And then making sure that we prioritise access for children and young people. So that's another plan that we're specifically working on to make sure that we get more access for children and young people, deal with the problems early, and then they don't come through to adulthood.
We hear a lot about calls for a dental school in Leeds. I didn't realise this, we're the only region without one. Is that likely to change?
I hope so. So the way the government does it is they don't commission a new dentistry school. They basically say, we are going to put out a number of places, basically. So they'll put out 600 new places in 2026, and you get to bid for them. So the existing schools will obviously bid because they'll want more places, and they'll be set up to be able to do that. But what we want to do is make sure that our universities are in a really good position to show that if they bid for some of them, they will be able to provide them, and therefore they can provide dentistry. So we've been working with the University of Suffolk, we've been working with the University of East Anglia and having those discussions. There's already a lot of work going on in terms of training dental hygienists as well. So we're building up that capability and that base. But I have to say, our MPs and councillors, some of whom are in the audience today, have been really instrumental in helping us campaign for that. And I really do believe that we are making enough of a noise to be able to get some of those places, and we'll get as many as we possibly can, because it will make a difference.
I love that you've reiterated the fact that change does take time. There will be a pressure to see progress soon, though. What are the next improvements for you, and sort of what we're going to see first, and what were you prioritising? Because there's a lot to change.
There is a lot to change. So we are continuing to work. So hopefully we will be able to have even more access to urgent dental services. We're continuing to work on that. Hopefully the 20,000 new patients that we've seen in the 5 months this year, I mean, if you extrapolate that over the year, then we'll be looking at nearly 50,000 new patients. If we can continue that, then we certainly will. And I think it's really about we're talking to dental practices, as many as possible, about becoming these foundation training hubs, so they'll be able to train more staff, so we'll be able to attract more people in. And this is also the postgraduate training they're doing. So the more of that we can offer locally, then the more people will be able to attract in from the dentistry schools around the country, which we've been talking to, and then we'll be able to have more provision. And I think that, working hand in hand with our councils on prevention as well, we will start to see all of that join together and make a difference. But on the one hand, we're working from a fairly low bar. We've never had so many dentists giving up their contracts, and we're working hard with them to help them keep the contracts and listening to them and what will make a difference as well. But it's just, It's great to have the power to do something locally, isn't it? And I think that if we all work together and we continue, and the team continue working and listening to everybody and getting all this information through, I do think that we'll be able to make a big difference. I hope we will.
Yeah. Finally, Tracy, money is the elephant in most rooms. There was an underspend within the ICB. Can any money be diverted into dental care? Does it work in that way?
No, it's not really the money that's the issue. It's the dentists, it's the actual professionals at the moment. That said, we put 6.2 million this year into transformation, and we do believe that we can spend that. I'm looking at Sadie. I do believe we can spend that and make a difference. And 1.2 million into the workforce initiatives, the Golden Hellos, all of that, the training to be able to attract people in. And we're hoping to spend more of that next year as well. So it's really about, any ideas, anything practically speaking. We're talking to dentists all the time about what we can do and where we can invest the money. So it's one of the very few areas in the NHS where money isn't the issue. It's resource, it's workforce, and that's what we're working on.
That's really interesting. Thank you very much. We have invited questions from the team that we've got here. If at any point somebody does, we will refer to this or do some questions at the end, whatever you'd like to do for that. That's great, but thank you very much. Now, before we hear from the perspective of a dentist, we're going to watch another case study.
When I moved into Norfolk in September 2023, I couldn't get a dentist anywhere for love or money. So fortunately, my dentist in Kent said yes, I could come back and have further treatment and remain an NHS patient. So it must have been January or February that I'd actually gone down to see them. They identified an area in my mouth where the tooth was. The dentist informed me that it wasn't something that he could do, that he would have to refer me, and that he would refer me. And then absolutely nothing happened. I was contacted a few days later by my dentist in Kent, who told me that the referral had been rejected because of the fact that my registered GP was based in Norfolk, which is where I was living now, and therefore I was out of their catchment area. But having been informed that, they would then refer me again, one assumes, to somebody in my area. We then go into maybe months and months and months of pain and silence. I then contacted huge amounts of people, from my local MP to NHS England, who didn't want to know about anything whatsoever. In fact, I would say were a complete and utter waste of time. And eventually, after weeks and weeks, probably 2 or 3 months of researching the whole situation, I ended up talking with, I think finally the correct people. There was my local integrated care board. I managed to get through to people. I identified my problem, what was going on. I was told that this would be looked into and somebody would get back to me. I had told them everything that had happened, that I'd been referred, that referral had been turned down, I'd then be re-referred. And the ICB eventually came back to me, a month or so later, to let me know that their dental unit had told the customer service people that their recommendation was for me to contact my dentist and ask them to refer me, which of course I'd already done. This aggravated me, to say the least. Bearing in mind, what you've got to remember is that I'm in pain all this time. And we're not talking about a couple of days, we're talking about months and months and months. And I was extremely fortunate because a gentleman called John Punt contacted me. He took on my case, he listened to me, he thought that I'd been treated disgustingly, and he's my hero. and within a reasonably short period of time, arranged for me to be seen by another dentist in Dis, who then referred me to the consultants in Cambridge, and the tooth was taken out. That whole period of time took something like about 9 months. What seemed to me incredibly, I don't know, frustrating, annoying, was the fact that the ICB, who were in charge of doing all of this, or making all the arrangements, didn't seem to have anything in place to be able to cope with the problem of me, having a dentist in Kent and wanting to go to somewhere in Norfolk to have treatment done.
Yeah, it's a tricky one, isn't it? I'm really fascinated with the case studies. I really think it helps build sort of people's experiences and allows us to really sort of think hard as to what some of the issues are. We're going to explore what life is like at the sort of sharp end of dentistry. The dentists themselves, they are people who are helping us every day. Jason Stokes is the Secretary of Norfolk's Local Dental Committee, and you're very welcome to...
Good afternoon, everyone. Is it working?
Yes, it is. We've got you. I think it would be really helpful to sort of go back in time a little bit, Jason, and know from yourself how you think we've arrived in this, I'm sure that gentleman would describe it, sort of a pretty dire sort of situation. What do you think?
I do have to go back in time. I have to go back to 2006. So in 2006, a radically different NHS dental contract was imposed upon the profession. Dentistry is quite a small profession compared to our medical colleagues. We are not only small in numbers, we are small in power. So whereas the British Medical Association would reject a contract which they felt was unsuitable for patients and unsuitable for the dental teams, the British Dental Association at the time did not have that power, and the option given to the profession was take it or leave it. I.e., if you want to remain as an NHS dentist, you have to take this contract. The contract was imposed, and very rapidly, the advantages of the contract, which were a better service for patients, better working conditions for dental teams, were not apparent. In fact, more the opposite were apparent. Dental teams found it very difficult to meet the terms of the contract, and this meant that practices were suffered financial clawback. So the system was changed thus that instead of actually the more work you did, the more money you were paid, it then became you receive this money per month, and if at the end of the year you haven't done as much work, give us the money back. So as a small business trying to plan around potentially having large amounts of income clawed back, this became incredibly challenging and difficult for practices. Because of course the patients who walk through the door one year might be quite different in their needs to the previous year. This contract also had a slightly perverse change to it in the fact that the amount of work that you did was no longer remunerated. So you could see a patient who required 1 or 2 visits and you would receive the same amount of money as if that patient required 10 visits. So as you can see, for a practice desperately trying to remain solvent, seeing new patients with very complex needs became rather unattractive. And you may feel that dental teams shouldn't behave in this way, but as you may or may not know, every primary care dental practice in the country is private. They are not owned and run by the NHS. The NHS doesn't pay for their premises, it doesn't pay for their staff, it doesn't pay for anything. And so if that practice is going to survive and deliver care of any sort to anybody, the numbers have to add up. And so when you hear about dental practices going private, most of the time it is simply to survive. It is not some way of living a gilded life driving around in a Ferrari. That is not the reality of becoming a private dentist. It is simply one where you can pay your bills and keep your staff employed. Unfortunately, that rather duff contract was noted very early on, with people from various political stripes saying, quotes, the contract was not fit for practice. Unfortunately, saying it's not fit for practice and then not doing anything about it left the profession rather frustrated and left the profession providing you with a service which you deserve better. Unfortunately, we have had pilots and prototypes of different ways of working. Most of these were rejected, unfortunately, because when dental teams were less stressed and put under less pressure, the throughput of patients that they were seeing reduced. And access seemed to be the only metric that various governments were primarily interested in. However, of course, if dental teams are spending more time with their patients and changing their behaviours to actually provide preventative messages, what you could actually see is a short-term drop in output, but a long-term increase in health. But unfortunately, that long-term strategy was not adopted. And so here we are today, where we still have the same contract that was introduced in 2006. We have a number of minor tweaks and changes which haven't really stemmed the flow of people leaving the profession. On top of this, we also have new graduates that enter the profession who see the strains and pressures that NHS dentists are under and don't see that as an attractive place to go and develop their careers in the future. They also see that they may have to work into their mid to late 60s, and of course a highly pressured environment that requires your eyes and your hands to be functioning at a very high level. Some of them think, I'm not sure I can do that. And so entering the profession has become less attractive as an NHS performer, an NHS dentist. And also the retention of individuals within the profession when there is little light at the end of the tunnel becomes more and more challenging. So I'm sorry if this story isn't very optimistic, but I'd rather tell you the truth, and I'd rather say what needs to change. Some other information that is worth noting: one of the major changes brought about by the 2006 contract was a ring fencing of the money that goes to NHS provision. Now, unfortunately, before 2006, approximately 50% of the population went regularly to the dentist. And so the money was capped at that. But then, of course, the costs of running and maintaining a dental practice have increased significantly over the last sort of almost 2 decades. And so the money available per head of capita in this country under the NHS has dropped dramatically. And the only way you can run a service with less money, trying to see more people who want to engage with dentistry, and more than 50% of the population are interested in doing that now, is if you radically reduce the amount of dental work that they require. And the only way you do that is through education and prevention. You will hear these words often this evening. You've heard them from Tracy, and you will hear them again from other speakers. The majority of dental disease that the population of this country experience is entirely preventable. But we have to change people's diets primarily and their oral hygiene secondarily. Those are 2 vital things. Unfortunately, the sugar lobby is very powerful, and there has been very little appetite to try and educate people into changing their diets, and sometimes perhaps placing restrictions around taxation and the availability of certain items which are extremely damaging to people's health. Sometimes there are political drivers to find that unattractive to make those changes. But if we are going to actually try and meet the needs of today's population, and more importantly the children who are the next generation, we need to not only treat the disease that they have, but to prevent that disease in the first place.
That's a lovely answer. Thank you. How would you make dentistry more attractive? Or how would you get more people to come to Norfolk specifically?
I mean, one thing to bear in mind is becoming a dentist is not unattractive. When the British Dental Association talks to government and says, NHS dentists have seen a 30% drop in their income in the last 5 years, and this is why people don't want to do it, the pressures are increased and the remuneration is dropping, and they also have very large student debts. This triumvirate of things just makes the thought of entering the profession less and less attractive. But they'll point out, but the number of people applying to dental school now is much higher than it ever was before. So clearly it's not unattractive. But that's disingenuous. More people are entering dental school to become dentists. Whereas when I qualified, a few years ago, people would qualify and automatically become an NHS dentist for the majority, if not all, of their practicing career. People now see that as a nasty little bump in the road that you might have to do for a year or two, and then you can go into the private sector where your life will be less stressed and your remuneration may not be reducing each year. The NHS brand was one that people wore proudly when I qualified in 1992. It is now seen as something that makes the job wholly unattractive. So there has to be a sea change around the available options if you become an NHS dentist. Are the possibilities to grow and develop as a practitioner? Unfortunately, Tracy's highlighted the needs of producing slots for urgent care, so people in the most need can be cared for. But the risk is if the NHS focus solely on urgent care, that makes the job less and less attractive to people who want to do the more complex work, that they could see themselves growing and developing into becoming a clinician who can provide that. But sometimes they don't see those opportunities under the NHS and so don't see a future there. So number one, we need to actually show people that there is a viable career structure within the NHS. And yes, part of that is money. Saying to people, you have a massive loan and your wage will go down every year, I don't see that really working out. So we need to stabilise and then perhaps show people how their incomes could increase. But more importantly, we have to say to people, and if you're an NHS dentist, you could do this. You could improve people's lives by using enhanced skills in a way that is just interesting and rewarding. And unfortunately, the role of NHS dentists often becomes one of putting out fires and not being able to then develop your skills in a way that could really help the people who need that the most. Making East Anglia more attractive, again, I think is the same thing. We need to actually say to people, you may not have thought of East Anglia, you might have thought of Norfolk and Waveney. We don't have a dental school here, and we don't have many people getting the 4 A's at A level you require to go to a dental school. But there are other advantages to living in Norfolk and Waveney. We have to sell the quality of life that we can offer, but we also have to acknowledge that we need a quality of professional life. Unless people think, if I go to Norfolk and Waveney, I can develop as a dentist, I think we may struggle to get 25-year-olds to consider the other aspects that I enjoy about living in East Anglia, and Norfolk and Waveney in particular. But unfortunately, I'm also 54 now, so I'm not the person you should be aiming for. You'll get a few more years out of me yet, but I don't know how many.
Really lovely. Thank you very much, Jason. Let's get your views on this now. Using the QR code on the screen behind us, you can vote yes or no for your thoughts around upskilling dentists. What do you think about the idea of upskilling dentists? We have a question here. Is there a roving microphone we could do, or do you fancy shouting?
I'll try and shout.
Oh, wonderful.
Does that work?
Mm-hmm.
I'm Vivian Clifford-Jackson. I'm trustee for Healthwatch. And I want to thank you so much for still being here and doing a fantastic job. I, in my family, in several generations, have been extremely grateful for orthodontic work, and I'm very aware of facial-maxillary work that may be necessary with cancer, with car accidents. And I'm also aware of the other end of the scale, what podiatrists, chiropodists are doing in developing musculoskeletal work. Is that a similar process? And I wonder what's happening to the orthodontic work for our children, because once that time has passed, it is so difficult to correct things in later life. So I wondered, is that also something that's incredibly attractive? I would have thought it was.
Well, I'll give you either some good news or bad news, depending on your perspective. Under the NHS, the vast majority of orthodontic work is not due to a structural problem. The vast majority of orthodontic work is primarily cosmetic. People having a jaw which is perhaps slightly away from the norm very rarely has an impact on function. And those individuals with a serious musculoskeletal discrepancy are almost always treated in secondary care in the hospital service. So the majority of high street orthodontics has some functional component, but that's not the vast majority of it. So we do have we have some orthodontic providers in the region who are still keen to provide services under the NHS. One of the limiting factors they have now is quite a number of orthodontic treatment plans may require the extraction of teeth. And of course, orthodontists don't take teeth out. I in jest suggested that one of my orthodontic colleagues should perhaps take some teeth out. I was given a very hard Paddington-style stare. They rely on the general dentist to do that. And of course, if patients are struggling to access general dentistry for urgent care, for something which is primarily of a more cosmetic bent, then you can understand why patients may really struggle to find access to the extraction of teeth for orthodontic care when people are struggling to find access to dental extractions for something that could have a very much greater impact on their health and well-being, such as an infection which could eventually lead to sepsis.
Yes.
Good evening, my name is Barbara Fountain. I'm the CEO of the Young Tongues. We're a peer-to-peer support group for young tongue cancer patients. Now, there is a 34% increase in oral cancers across the country, actually 103% increase over the last 20 years in England alone, a trend that keeps going in the same direction. So we know the workload for dentists and MaxVax and so on will increase. Dentists are extremely important in identifying cancers through regular screening. We have talked about prevention. For a certain age group, prevention is a relevant topic to discuss, but we're also seeing an increase in younger patients in their 20s, 30s and 40s, namely a 385% increase in those patients coming forward with tongue cancer without risk and any way of prevention. Our community struggles to be heard by dentistry. They have extreme delays to their diagnosis and they really struggle to access to NHS dentists for regular care after their treatment, some of which have reported back annual sums of up to £12,000 in costs just to keep their teeth, which is not really possible. What is your view in what's ahead of us here in Norfolk and further afield in trying to prepare for that increase in workload?
That's an excellent question. Thank you for asking that. When I mentioned earlier that we had a system produced in 2006 and there has been relative sclerosis in that system, the problem with having a system put in place that wasn't really suitable in 2006 and becomes increasingly less suitable is it is incapable of adapting in the way that we would like to significant changes in disease prevalence. And that change that you mentioned, which, by the way, you may or may not be aware of this significant increase in oral cancer, it's also, there's been a significant increase in bowel cancer amongst much younger people. So as we see these shifts in disease prevalence and incidence, we need a system which is fleet of foot, a system which can adapt to these changes. And unfortunately, over the last 18 years, we've had a system which nothing has changed, nothing has adapted. And so when we have guidance about how often we should see patients, we have guidance issued by National Institute of Clinical Excellence. That makes it quite clear that we do a risk assessment. But as new data comes forward about the prevalence of diseases like oral cancer, we should change our risk monitoring. And so individuals perhaps we would have seen every 2 years, which is the maximum recall guidance for NICE, we may actually change that based on new evidence that's coming along. But as we have a system which is incredibly overburdened, although I try and work to a risk assessment basis, I try and work to the NICE guidance, but also modify that based on new information as it comes through, with some colleagues finding it very difficult to look up. And what I mean by this is increasingly stressed you are, and you probably all see this in your own lives, that the more stressed you are, the more difficult it is to plan for the future. The more difficult it is to make anything other than a decision today about what's happening today. So what I find when I talk to my colleagues is I'll say to them, but what about these changes in prevalence? And they go, look, I'm just struggling to pay the lease this month. And thus it's more difficult to become this kind of nuanced and adaptable clinician if you are constantly under strain financially and desperately trying to provide a minimum service level for your patients. This is when an added change just becomes one more plate you can't spin. And so the ability of the system to adapt to these changes and the changes in disease prevalence are weakened by the overall strain on the system. So does the group that you represent deserve better? Yes. I think everybody deserves better from the system. Is the ICB trying hard to fix a problem which is not of their making? Absolutely. The local dental committee is here to represent dentists, particularly NHS dentists. And my job quite often brings me at loggerheads with the NHS commissioners. I have had a much better relationship with the Integrated Care Board than I had with the previous commissioners, NHS England. But they have been left with a broken car that needs everything fixing. So that does take time. But also we do need to acknowledge that the systems that have existed for 18 years and failed us are only going to fail vulnerable groups that are new and perhaps we are not expecting. So we need to be open-minded. We need to make sure that we're not just looking down, that we are looking up. And we need to have a system which is capable of being flexed to actually suit the new challenges that come along. Some of my colleagues made changes to their practice and their practicing lives during COVID within days, which I find absolutely unbelievable. The profession is capable of making significant changes. We're not totally hidebound, but you need a system that facilitates and allows that. Unfortunately, of course, some of the colleagues that made significant changes during COVID also found that they were punished for actually trying to treat people during that period rather than supported afterwards. And that actually did encourage some practitioners to leave the NHS on the back of that because they felt that they'd been insulted, frankly. So we do need to be careful that if people have got novel ideas of supporting vulnerable groups, that we listen to them and see if there are ways of supporting them. And again, I will support my colleagues with in the ICB. We've got new initiatives around things such as child-friendly dental practices, which are looking to work with some of the most vulnerable children in our region. And that kind of innovative thinking could really be helpful for your particular group and many other groups we'll see coming along, new challenges that we just don't know about yet. I feel slightly uncomfortable quoting Donald Rumsfeld, but when it comes to the unknown unknowns, we need a system that can go, actually, we never had a system designed to cope with this need, but this need exists now, so we need to deal with it.
Thank you.
Thank you. Would you like to comment?
Thanks, I'm Alice MacDonald. I'm the new Member of Parliament for Norwich North. Thank you very much for organising this. I think Healthwatch, and for me, I think during the campaign of Knock on People's Doors, you can guarantee that dentistry will come up. I did my own survey and found similar results. My first question in the Houses of Parliament to West Streeting was on dentistry, and he described Norfolk, which won't be a surprise to many people here, as the Sahara of dental desert. So there is clearly a recognition, and you will have seen during the campaign and the manifesto that the Labour Party put forward some of the things in that, which included reform of the dental contract. I know you've touched on it, but what I know it would probably be too easy to get into all of it, but what do you think would be the key things for reform of the contract and the message that you want government to be hearing right now in terms of that?
I was talking to one of your colleagues recently who seemed somewhat shocked by my answer. He said, it sounds to me as if we need a new contract. And I said, I'd be very careful as a Labour MP suggesting a new contract, as Labour brought in the last new contract in 2006. So we don't need a new contract. We need one which is fundamentally better, serves the patients and the dental teams in the way we were promised with the last one. And that is clearly obvious. Because if a dental contract is brought in, which doesn't clearly improve the lot of dental practices, you won't have a drip of people leaving. That will be, we've had people hanging on since 2006 with promises of, quotes, a new contract. If it is not a clear improvement, then I think the last dying embers of NHS dentistry will snuff out. I don't want to sound too hyperbolic about that, but everybody I know who still works on the NHS is doing it through an enormous number of challenges, both financial, personal, psychological. They can't cope with one more, with the plate spinning analogy I used, they can't cope with one more strain. And actually just making a change from the existing contract even to a better contract is an additional strain. Because sometimes you'll find things that work and things that won't. Funding is an issue. I mean, all we hear currently is that there's no more money. I mean, if that is going to be the case, then honesty with the public. If there's going to be no more money, currently we have a terrible system for everybody. Do we say we're going to continue providing a terrible system for everybody, or are we going to be honest and say people who can afford are going to have to pay, and people who cannot, the really truly vulnerable, will receive a better quality of system? I think most NHS dental practices would prefer something based around capitation. For those of you who are unfamiliar with the term, it would be given a sum of money to look after a set number of people and to actually have a relationship with those individuals. It's then my job to try and prevent that individual from getting disease, because the more I have to interact with them, the more that costs me money. And now there are downsides to a capitation system. Clearly, some people could take the money and run, but the vast majority of people I know that work in Norfolk and Waveney are decent, ethical individuals with a long-term urge to live here and help the people that they see on a daily basis. Also, the previous new contract that came in 2006 abolished registration. So I still occasionally hear members of Parliament and also members of our local government say, this patient's been deregistered. So, are they a private patient? No. Are they an NHS patient? Yes. Yeah, they were deregistered in 2006 and central government did it. What are we talking about now? If an NHS practice says we can't see you next time because we've run out of contract or we don't have the workforce, that's not deregistration. That's the system that the NHS is now. You have no long-term relationship with your NHS practice if you're an NHS practitioner. They have no duty of care to see you. If they have seen you up until now, that is through the goodness of their own heart and good luck. Luck runs out, and sometimes, unfortunately, people's ability to be kind to you can run out when you are struggling to keep the lights on. I think most dental practices would prefer a long-term relationship with their patients where they can build on the health of those individuals and make real changes to people who need their health improving. It's very difficult to do that on ad hoc one-off visits with people where there was a phrase from the television programme ER, which some of you might remember, and many of you in the room won't because you're too young. But it was an American television programme about an emergency room, and they used to say, we just treat them and street them. Most dental practitioners do not want to work like that. That is not a way of generating a sense of community, a sense of that you have a place in people's lives to help them. I have lived and worked in Norfolk long enough now that I treat the children of the children that I used to treat. That gives me an enormous sense of well-being, but it also gives me the ability to say to people, your kids have been eating sweets. What did I tell you when you were their age? And what did I tell your parents? Because you're going to get that message again. Right? And I'm going to keep telling you until you don't come here anymore or we stop with the sweets, okay? And I can have that sometimes quite brutal conversation with people because they know me and trust me. The other thing is I work with new graduates who come to the region, and one of the things they're terrified about is they're terrified about being sued. So as a dentist in this country, so I remember somebody saying to me, Jason, it's getting like California. Oh, I wish it was like California. We've had higher rates of medical legal interactions with dentists in this country compared to California. I think that we tipped that precipice about 20, 30 years ago. So practitioners are scared. However, the better the relationship you have with patients, and that is a long-term built relationship, the more goodwill you have, and the more occasionally, if you get something wrong, people will give you the opportunity to fix it. I don't know if that's the answer you wanted, but it is an answer. But I would say that if you would like an answer, speak to the British Dental Association. They are the trade union. They do represent dentists. And I think it's important that you don't take one person's opinion, you take the opinion of actually the representative organisation. And I know the BDA has had meetings with WES, but I would strongly encourage you to speak to them. The risk is I go off piece and I say something. I hope I haven't said anything that's too counter to the BDA and I get into massive trouble. But fundamentally, practitioners need support. They need to feel as if they have funding that meets the needs of the population that they have, and they can viably maintain a business that can support that population. And I think they want a long-term relationship with that population and to feel that they have responsibility for them. It's my job to keep you all healthy. I think they're happy to take on that responsibility, but there's been a lot of push to actually separate that bond. Actually, I'm just going to do a pop quiz. Sorry, no Mentimeter. Sorry, they've given me the microphone. I'm not going to put it down. Bad luck. Anybody who thought they were going home by 8 o'clock? No, so it'll be dragged out of my cold dead hand at some point. So, hands up. Who has their own GP they can see whenever they want, a named contact? Their own GP who is a named contact and they see the same GP over and over again. Do you feel lucky to have that? Do all your family members have the same thing, family members? Mine don't. And by the way, if you look at the data, the more frequently you see a GP, the better the quality of care that you get. Right? And the problem with dentistry is that long-term relationship between patient and dentist has been broken down by the 2006 contract. And if you want to make dentistry more attractive, you want to make people a part of the community and make them feel like they're achieving something. It's not just money, although you do need to pay your debts and pay the bills. It is that sense of self-worth and the sense that you are helping people is really important.
Can I just say, sorry, that I fully agree with everything you're saying and you want that long-term relationship, and I've had that in the past. But at the moment, I would be glad to see that one-off dentist and just see them once, have a course of treatment and possibly never see them again because I haven't been able to see dentists.
I completely understand that. When people have been denied food, you'll have a dry slice of bread rather than a proper meal to support you. But not only is that not necessarily good for patients, it's not good for us being able to recruit to the area.
Yeah, I sort of understand that, but from where I'm sitting, I can't see anybody.
I totally understand. It is important that we address those primary needs, but we have to acknowledge the need to build a workforce for your children and your children's children and the next generations coming down. And I think by focusing solely on can we just acutely put a sticking plaster on this, we let the system die because of other strains on it. And I think we just need to acknowledge the acute and the long-term goals that we need. We need to look up, as I said earlier, there are too many people not thinking of a long-term strategy because they're so desperately trying to fix the issues now.
We're going to look slightly at long-term strategy now because we're going to talk about prevention and what can be done to avoid sort of that acute dental care in the first place. We're going to focus on specific projects going on in Norfolk at the moment in a few minutes, but firstly, public health here in Norfolk does play an important part, it has an important part to play in this. We've had some information around the wide range of work that they are doing, particularly related to children and young people, and there's a short video about to play now.
Dental decay in children and young people is largely preventable. Multiple studies make it very clear that things like improving nutrition and diet, supporting the development of early oral hygiene routines, supporting access to fluoride, and promoting the work that dentists and dental practitioners can do can all make a difference. Equally, there are challenges around health inequalities. To give some examples, let's focus on 5-year-olds in the area. A 2023 government survey showed that cases of tooth decay and cavities among 5-year-olds in Great Yarmouth, Kings Lynn and West Norfolk are higher than in other local areas. In fact, around a third of 5-year-olds are thought to suffer from tooth decay in these areas. Work's since gone on to map existing public health prevention work, collating it with the needs, to see what's in existence to help and what could be developed to meet needs in the future. The current work going on is the Early Childhood and Family Service, or ECFS, which works with plumbers' dentists to offer dental screening sessions in Norwich, Broadland, Great Yarmouth and South Norfolk. Families are encouraged to drop in, they're seen by a dentist and will be offered an appointment if needed, although they won't be registered with the practice. They'll also be offered an information pack about brushing, as well as a toothbrush and toothpaste. The County Council also offers physical health and mental well-being lessons in schools. This includes sessions on a healthy diet, the risks of unhealthy eating, and dental health and the importance of good oral hygiene. A Norfolk Oral Health School Toolkit's been developed by County Council Children's Services, which provides guidance and resources and will include ways of the whole school sharing both what's working well in terms of oral health and where things could be improved. Public Health commissioned health visitors, school and community nurses, and their teams are also providing support and guidance around oral health for under 19s. This includes help and support for parents around diet, oral hygiene and toothbrushing, plus support and information via home visits for those children aged 0 to 5 and their families. As part of the Public Health Healthy Child Programme services, the Just One Norfolk team also provides help and advice by phone, telephone or text, and there are also detailed online resources on their website too. Norfolk's family hubs can provide oral health improvement support for parents and young carers of under 25s. And Start for Life also offers help for parents for carers of those with children aged 2 and under around areas like infant feeding, teething, tooth and toothbrushing. Meanwhile, Community Dental Services CIC, commissioned by the NHS locally, have worked on the following projects. The Healthy Smiles programme, which encourages early years youngsters and school pupils to adopt tooth-friendly practices, which includes supervised toothbrushing. Alongside this, CDS work with both children and adults with learning disabilities who may or may not be in a residential care home. Also in partnership with CDS-CIC, specific areas have also been targeted for help. 4 dental community projects have been set up in different parts of Norfolk in the West, East, Broadland and Breckland districts. Partnering with a number of organisations, including early years providers and libraries, it sees story sacks with puppets, books, toothbrushes and other resources for families to take home. Over 1,000 children have already received awareness of oral health through this system. We do also know that voluntary, private and independent early years providers across Norfolk are also doing a lot of work around this issue. So what happens next? We want to make sure oral health is included within all work done around health with children and young people, promote themed days like World Oral Health Day and National Smile Month, and also ensure the importance of oral health is rolled out through primary and secondary schools, with all pupils and students getting information and being encouraged to take part in initiatives. Ensure oral health promotion training is rolled out to all staff who work with children and young people, as well as other key stakeholders such as local leaders who can promote consistent messages on preventing tooth decay. And, particularly in those areas where oral health is a problem, target help to families and schools to develop community fluoride programmes. There's also the potential, with new laws in place, Norfolk might develop local water fluoridation schemes, which are known to be a safe and effective public health measure and could benefit everyone's oral health. All this work is going to continue as organisations work together to ensure good oral health is a priority for future generations.
There's a lot going on, isn't there, in that? earlier on in the video, Amanda Turner is the Oral Health Improvement Manager with Community Dentists. So it's really nice to meet you. Thank you so much for coming along. The video touched on there what you were doing. Tell us in a little bit more detail about the work you do.
So the work we do is looking at the Healthy Smiles programme, and it covers supervised toothbrushing, and they are looking at 7 standards for early years settings to meet, and we look at accrediting the settings. We focus on 3 to 4 year olds and look at reception age group and also year 1 age group as well. It's trying to get those, as it's always been said, those key messages in and look at long-term behaviour changes around establishing those good oral hygiene messages and oral hygiene cleaning, so with the supervised toothbrushing and making sure that the diet, as part of the programme, we encourage the settings to be a tooth-friendly setting, so that those sugary items are not going to cross the threshold. So they're going to have nice, healthy snacks being provided at the setting, and then they're providing for events throughout the year and birthdays, non-food related celebrations. So we look at then trying to avoid all the sugary items that are being consumed in between meals, which is where the problem lies.
You've had some real success stories so far at both ends of the age spectrum. Can you tell us a little bit about that?
So that's just working with the Healthy Smiles, and we are then covering all areas across Norfolk, and we do focus on those areas that are in high deprivation. So when we're looking at statistics from the 5-year-old dental survey, we then look at those focused areas, and our focus areas are Norwich, Kings Lynn, the Breckland region, and also Great Yarmouth. Unfortunately, Great Yarmouth for our Norfolk County is one of our worst counties for children with prevalence of dental decay in 5-year-olds. So that's a huge area that we do focus on, and trying to establish those Healthy Smiles programmes and get the supervised toothbrushing in place. We also work with adult social care and creating oral health champions, and the video mentioned around the work that we do with upskilling and training everyone in oral health messages, so they can then use their information that they've gained to then work with all of the people they're working with in the community. So a lot of our work is the train the trainer module, so we can upskill everyone, so that key message is out there all the time, and we're focusing and talking about teeth and talking about prevention, and make sure that prevention is a little bit more on the forefront of people's thoughts rather than going down the route of having to do that, need to have the treatment done. So we want to put, as everyone's talking about, prevention first.
Yeah. Stay there for us, Amanda. We're going to have a little look at a case study here of Little Sparks Nursery.
We were contacted by them and asked if we wanted to be part of the programme. And Amanda came in and told us about it, and then we did a little bit of training on it to see, how it was going to work out. And at first you're a little bit, can we manage this? When we first start in September, we usually don't have a lot of children, but as the year goes on, we get up to our full sort of 24. But in actual fact, she was very helpful, and once she got going on the programme, we could manage it, The ethos of the programme is to support us to encourage the children and families with their teeth cleaning routines. And the routine is broken down, so we tend to find that the children go and wash their hands, they come and sit at a table, they're spaced on a table, they have a piece of kitchen roll, we put a little bit of, they all have a named toothbrush that goes into the stand, and then we put a pea-sized piece of toothpaste on their kitchen towel. They then put that on their brush, clean their teeth for the 2 minutes, and then we then collect up their bits and pieces. They come and we do the brushing separately, one at a time. We just rinse them. We've got a little stand. It's all quite hygienic, and we, regularly we have to clean the stands, and we clean all our bits and pieces that we use. So the children very quickly got into that routine, and then from time to time, like I say, Amanda comes in and kind of helps us to make sure we're doing it all right. So I think it was good to be part, initially to be part of the campaign. I mean, one of the children said, I don't like cleaning my teeth because it's boring, but if I don't, my teeth will fall out and they get rotten. If I had toothache, it would make me cry and sad. What about she could get a fun toothbrush, you know, so it wouldn't be so boring. And, you know, I think it was really important to clean her teeth. And she replied, Mummy's friend lost her teeth in the lake. Apparently she did. The support from Amanda, again, I could use her because it's not easy. The tooth cleaner, the children get it. So that part is okay. We got lots of leaflets. So you get kind of, I could access things online that she sent through to me. So that it's about teeth cleaning. It was also quite nice because you then get a whole kind of setting. So when we do our children's role play doing a dentist, I could then get up a whole lot of things about teeth and make up our own surgery. You've got the waiting room and you've got stand here and then you've got all the pictures of the equipment in the dentist. So the children kind of really feel, you know, so it's set up, you know, when we set up our role play, it's like you're all going into the dentist with all that. When it's their birthday, we do a little celebration here, but we have a birthday hat, we sing happy birthday. And then suddenly some of the parents have kind of got into, they wanted to bring a birthday cake, they wanted to bring, you know, packets of sweets. So it had sometimes, unfortunately, at the door, we've had to say to the parent, no, unfortunately, you know, as we explained, as you saw in our brochure, as you explained in the policies, we're following the Healthy Smiles, we really can't have the cake. You know, so that's been a little bit of it. You know, we've had to sort of stand our ground on it a bit. But a lot of them now are bringing in fruit, you know, and so some parents get it, they're really on board. Sometimes you get caught out, you know, because at Christmas we found that one of the parents in the, you know, they sent Christmas cards to the other children, and each Christmas card was a chocolate coin. So from that point of view, it's kind of not that we're banning everything in that respect, but it's kind of how it's a soppy. You know, the more you sometimes push it, perhaps that's when some parents are a little bit resistant. You know, so again, it's like working on packed lunches and what is, you know, what's appropriate. Oh, go for it. I mean, it's made us more proactive.
That's really, it's bordering on like a real cultural shift that's being proposed. It's really, really interesting because it goes deeply into how families are raised and my son is between 3 and 4, that age. I had, truth be told, no idea when I was meant to start brushing his teeth. Do you brush gums? Do you brush, like, at what stage do you was it like that information actually isn't there, and you think you just absorb it. I mean, I had a very privileged upbringing. Like, there's no, like, I could have Googled it. I just didn't think. I just, you know, at what age do you start brushing? He does brush his teeth. I don't, you know, but I'm doing it with him. I do his teeth for him. I have no idea when that transition should happen. I imagine that must be very challenging for you, Amanda, sort of reaching people.
It's trying to get those messages out, and having Healthy Smiles programme and having all of these programmes where you are working with settings and you're working with families to get the messages out there and have that consistent message. So you have a child of such a young age that people don't understand that actually the responsibility is for the parent to do the brushing until they're roughly about the age of 7 to 8 years old. And a lot of, so now you know. So there's an awful lot of parents that would then be quite happy for their children at such a young age to have that independence, but they don't have the manual skills and the dexterity to be able to do it effectively and well enough on their own. So the parents do need to do that. And also then you have the battles as well of that age group not wanting to brush their teeth, whereas the programme with them brushing with their peers, the outcome that we're experiencing from parents is that they don't have the battles at home because they're so much more engaged about brushing, and it's just taking that edge off wanting to do it. We're now engaged to do it, and that's huge feedback that we're getting. And they're making positive changes around the foods that their choices that they're taking as well, because that's all the conversations that's been happening as part of the programme. So there are challenges, and as Jackie has pointed out, we still get the sugars that want to come across the threshold.
You can't argue with it though. No. You can't argue with like your intention.
Yes.
And I think that's, as so that it's like a real cultural shift. Aside from anything, bringing packets of sweets into a nursery setting, can you imagine having to care for however many young people that you're looking after when
When
they're
they're high on
had
sugar rush?
It's bad enough with one. Oh my goodness.
Yeah.
It's really, thank you very much for coming on. Stay there, because there might be questions for you a little bit later on, if that's okay. And we'll talk perhaps a little bit more about prevention as well, and the audience may have questions too. But before we do, we're going to bring you one final case study with you.
I think we've always sort of had problems. I think so. Aurora's turning 6 at the end of this month, so about 6 years now. She's never seen a dentist. It's impossible to find an NHS dentist that will take children. So right from there, I have my mum, who's always had sort of dental issues who've just gotten worse over the years. She's not able to get an NHS dentist either. My partner has gone on an emergency appointment for an NHS dentist, and then they said to him that he needed certain work done. No dentist available to have that work done either, unless you go private. So just been an all-around thing for the last few years. Every single dentist in a 50-mile radius. They don't have any NHS placements at the minute. They're not taking children. If we want a dentist for her, we're just going to have to go private. Is basically they could. We could register her, but only as a private patient. Even now, we've only just recently found out she's got a tooth growing on her bottom jaw, but none of her baby teeth have fallen out yet. So it's obviously overcrowded. It's growing behind her tooth line, and there's no way to find someone to even see her. I have a sister who had quite a few dental issues when she was younger, and that affected her eyesight. It affected migraines. I mean, infections, and ended up infecting her blood. All of these things are part of a person's health in general. You know, when you think dental, we think teeth, but it's not just teeth. It affects a whole area of health that you can't follow through. I think the priority really is, dental treatment for children. It's massively important. Like I said, it has to do not just with their dental treatment in itself, but all of the health issues that can arise from a dental problem, from not having that sort of treatment and that sort of preventative care. And, at the end of the day, even for the NHS, it's money saving to be able to have that preventative care for children from the beginning, rather than, letting it go. And now we have adults that need to emergency care, that are in NHS hospitals, that are taking NHS emergency appointments.
Really interesting, isn't it? So another perspective there. We've had loads of information today. Thank you to everyone who's participated. All of your sort of thoughts and views will be sort of used, and it will be sent across to the ICB and to all of our panellists as well. So, information is really important. So, the key point that you've taken from today, should we see if there have been any questions on the QR code? We'll pop them on the website. Yes, sorry.
If there was, we're waiting maybe. I made a note that I thought, I don't know if anyone else picked up, because we heard this, I'm so sorry, the first speaker, your name was Tracy, that you mentioned early on that money wasn't the problem, but then we heard very clearly that when it came to the dental contract, that money is a problem. And I was wondering if any of the big organisations are conducting any research to see what impact it has, long-term costs on a society, from an NHS perspective, from a benefits perspective, from a governmental perspective, by not having a fit-for-purpose dental system. Because if we are going to ask the money from government, which is who's in the room, I think we need to be fiscally robust in order to make a point that investment and more money for better contracts is long-term beneficial. So I don't know if that work is happening and if Healthwatch is engaged with that.
Brilliant, it's a really good point. Thank you very much for it, and we've got it. It's been recorded on the ether somewhere. I'm going to hand back to Healthwatch Norfolk Chair Patrick Gill to sort of wrap up the event today. But I think if anyone does have any further questions, please find a Healthwatch representative, and that will be taken down, and sort of those points will be also teas and coffees, no biscuits then.
Well, thank you very much to everybody for all your contributions, and thanks to the audience for coming along this evening. Just as we've just said, we will be publishing the key findings on our website, and if there is more feedback, then please share it with us, because the more we hear what people have to say, the more we can feed into the system to make sure that the system is trying to represent us as well as possible. And before I go, I'd just like to say a few thank yous. First of all, thank you very much to Anna for coping with the IT and looking at these ginormous QR codes, which are spectacular. Tracy, and to all the other speakers, thank you very much indeed for coming along and hearing the tales of woe from so many people, from the case studies and also from people in the audience. Thank you to the Garage for hosting us here today and for putting on a really useful venue for us. It's perfect for what we're looking for. A big thank you to AstraZeneca again for helping to fund this evening. And finally, to my Healthwatch Norfolk team, who I think are absolutely amazing and go out in all weathers to capture people's points of view and to do it in such a way that the health and social care providers across Norfolk still listen to us, even though we don't always bring them what they want to hear. Thank you very much indeed, everybody, and do keep in touch with everything that goes on.